Hi, this is William Huang and welcome to the anatomy section of hematology and oncology. Blood cell differentiation and nomenclature are fundamental to learning about disease processes. Blood cells all begin as hematopoietic stem cells, or HSCs, that can transform into any type of blood cell. HSCs can divide to maintain the stem cell pool, or in response to different stimuli, they can differentiate to either the myeloid lineage or the lymphoid lineage. When we think about cells responsible for immune function, we usually think about white blood cells. White blood cells are made up of cells from the lymphoid and the myeloid lineages. Here you see the different types of white blood cells listed in order of most common to least common: neutrophils, lymphocytes, monocytes, eosinophils, and basophils. The mnemonic, neutrophils like making everything better, may help you remember this order. The first type of blood cell we'll discuss in detail are red blood cells, or erythrocytes, from the Greek erythros, which means red, and cyte, which means cell. These cells are descendants of myeloid stem cells whose function is to facilitate oxygen and carbon dioxide gas exchange. They are biconcave and have a large surface area to volume ratio to enhance exchange. Of note, the membranes have a chloride bicarbonate antiporter. This is important for the physiologic chloride shift that enables carbon dioxide transport. This topic will be covered in more depth in the respiratory section. Interestingly, mature erythrocytes do not have nuclei. Immature erythrocytes do have nuclei, but they extrude them during the maturation process. One particular form of immature erythrocyte is called a reticulocyte, which is the name for a developing red blood cell that has just lost its nucleus. These reticulocytes have a distinct appearance because of the presence of ribosomal RNA in their cytoplasm. An increased reticulocyte count is a good indicator that the body is actively making new blood cells, like when you're replacing blood after hemorrhage, hemolytic anemia, etc. Conversely, what do you think is going on if you know there's increased erythrocyte destruction but a normal reticulocyte count? Something is wrong with erythropoiesis, or new red blood cell formation. Here's some additional vocabulary regarding red blood cell pathology. Low counts is called anemia, while high counts is called polycythemia. Anisocytosis refers to varying sizes, while poikilocytosis means varying shapes. You can see poikilocytosis in this iron deficiency blood smear. The next cell we will discuss is the thrombocyte, more commonly known as a platelet. Platelets are also in the myeloid lineage and take part in primary hemostasis, a topic that will be covered more later in this chapter. Platelets are small cytoplasmic fragments that split off from megakaryocytes. There are normally 150,000 to 450,000 platelets per microliter, and they circulate in the blood for 8 to 10 days. This is why a patient who has taken aspirin requires at least a few days to recover platelet function, as new platelets replace old, irreversibly inhibited platelets that die off. The distribution of platelets is also interesting in that 1/3 of the total platelet pool is typically found in the spleen. This is why patients who have splenomegaly can become thrombocytopenic or have a low circulating platelet count because vastly higher fractions of platelets end up in the spleen. Conversely, patients who have no spleen, which is known as asplenia, or who are functionally asplenic because their spleens aren't working properly, can have thrombocytosis, or an elevated platelet count, since that 1/3 re-enters the bloodstream. When the endothelial layer of a blood vessel is damaged, platelets are activated and interact with von Willebrand factor and fibrinogen to form a hemostatic plug. They have two main types of granules that are released when platelets are activated: dense granules, which contain ADP and calcium, and alpha granules, which contain von Willebrand factor and fibrinogen. Thrombocytopenia or platelet dysfunction can lead to increased bleeding time, characteristic red dots on the skin called petechiae from vessel bleeding, and mucosal bleeds like epistaxis, menorrhagia, and gum bleeds. This image shows petechiae on the abdomen. Platelets also have a number of surface receptors that bind the various substances stored in their granules. These types of receptors are the targets of many drug classes which are designed to inhibit platelet activation. For example, platelets have ADP receptors that bind the ADP released from their dense granules, and drugs like clopidogrel can block this receptor and inhibit platelet activation. Other important surface receptors include GP1B, which binds to von Willebrand factor, as well as GP2B3A, which binds to fibrinogen. These receptors also serve as sites of action for various drugs that we'll discuss in the pharmacology section of this chapter. This scanning electron micrograph shows red blood cells, several white blood cells including lymphocytes, a monocyte, a neutrophil, and many small disc-shaped platelets. You can see that the red blood cells and platelets greatly outnumber the white blood cells. Leukocytes, from the Greek leuko for white and cytes for cells, are the immune cells that fight infection. Normal concentrations are 4 to 10,000 per microliter. There are two main types of leukocytes. First, the granulocytes, which contain many granules and have lobed nuclei, includes neutrophils, eosinophils, and basophils. Second, the mononuclear cells, which includes lymphocytes and monocytes. Let's talk a little more in depth about each of these various types of leukocytes. Neutrophils are the most common leukocyte type, making up 40 to 75% of white blood cells. They are found in blood and tissues and take part in the acute inflammatory response of the innate immune system. Neutrophils are sometimes referred to as polymorphonuclear cells, or PMNs, because they are characterized by multilobular nuclei. Also, neutrophils characteristically have large, spherical, azurophilic or bluish granules filled with hydrolytic enzymes. For practice, let's try our hands at a sample boards question. A 32-year-old strict vegan comes in with extreme fatigue. CBC shows anemia, and this is the smear. What's going on? The answer is B12 deficiency. Folate and B12 deficiency characteristically show hypersegmented PMNs. Normal PMNs have 2 to 5 lobes. The PMN shown on the blood smear shows 7 to 8 lobes. It is important to know how these deficiencies present clinically, but we'll leave that for another discussion. The name monocyte comes from the roots mono, meaning one, which refers to the unilobular nucleus, and cyte, meaning cell. They are of myeloid lineage and make up 2 to 10% of leukocytes. When monocytes leave the bloodstream and enter the tissues, they differentiate into macrophages and dendritic cells. This smear includes a monocyte, neutrophil, and lymphocyte. Can you identify each one? The monocyte is the largest and has a unilobular kidney-shaped nucleus with frosted glass cytoplasm. The neutrophil has a multi-segmented nucleus. And finally, the lymphocyte is the smallest and has the highest nuclear to cytoplasm ratio. Macrophages are descendants from the circulating blood monocytes we just talked about and take on the name macrophage once they've entered tissues. The name macrophage comes from the roots macro, meaning big, and phage, meaning eater. The name gives you a pretty good idea of its main function. They phagocytose bacteria, cell debris, old red blood cells, damaged cells, and tissues in their role as part of the innate immune system. Damaged tissues release chemokines that attract monocytes to the site. Once on site, they morph into macrophages that can remain there for a long time. They will usually release cytokines like interferon gamma to recruit and activate more macrophages. Macrophages can also present phagocytosed antigens on MHC2 receptors to trigger an adaptive immune response. This dual role in both innate and adaptive immune systems is a relatively distinct feature of macrophages. One important cell marker that can be both stained for and used to quantify macrophages is the surface CD14 molecule. This is one of many CD, or cluster of differentiation, surface markers that we'll talk about, particularly when we discuss B and T lymphocytes. Eosinophils are named from the roots eosin for a red acidic dye and philic for loving. Eosin-loving cells are myeloid lineage granulocytic leukocytes. As you can see in this smear, the cytoplasm is replete with pinkish-purplish granules. There are a number of important functions for eosinophils. The first function is to defend against invasive helminthic or protozoan infections by deploying major basic protein. They can also act as phagocytes for antigen-antibody complexes and even help modulate allergy and asthma response. They perform the latter function by releasing histaminase and aryl sulfatase that limit the allergic reaction after mast cells degranulate. Eosinophils normally only make up 1 to 6% of leukocytes, but several disease states can cause eosinophilia. It may be helpful to remember the mnemonic NAACP for neoplastic, asthma, allergic process, collagen vascular disease, and parasites that invade. Next up we have the basophil, a myeloid leukocyte involved with allergic reactions that only accounts for less than 1% of total leukocytes, making it one of the rarest white blood cell types. These are intensely basophilic cells that stain purple with basic dyes due to dense basophilic granules. During certain inflammatory reactions, these cells release granules containing heparin, which prevents clotting. histamine and vasoactive amines that cause vasodilation and increase blood flow to tissues, and leukotrienes, which mediate the inflammatory response. Mast cells mediate allergic reactions. Responding to the Fc portion of IgE attached to antigen, they release histamine, heparin, and eosinophil chemotactic factors. Allergic reaction is a type 1 hypersensitivity reaction like asthma, hay fever, allergic rhinitis, etc. Can you name a medication that can block mast cell degranulation before it happens? The answer is cromolyn sodium, which is used in asthma and other mast cell-mediated disorders. Switching gears away from the leukocytes, we turn to the dendritic cell. They have a characteristic star shape with several arms that allow them to sample and explore their surroundings. They are professional antigen-presenting cells, meaning they are the best at doing this job. Macrophages and B cells do their best, but no one can beat the antigen-presenting function of dendritic cells. They express MHC2 and Fc receptors on their surfaces. They are the main inducers of primary humoral immunity, or the antibody response. Dendritic cells are called Langerhans cells when located in the skin. Remember this when you hear about Langerhans cell histiocytosis, which is commonly known as histiocytosis X. Later on, we'll talk about how to recognize Langerhans histiocytosis X cells. On an electron micrograph, you will see characteristic Birbeck granules that are shaped like tennis rackets. Now let's move on from the myeloid lineage to the lymphoid lineage of cells. Lymphocytes are round cells with densely staining dark purple nuclei and very little pale cytoplasm, which is dramatically different from all the cells in the myeloid lineage. There are two main types, B cells and T cells. B lymphocytes are a type of lymphocyte that is made and matures in the bone marrow. Their main role is to produce antibodies. Like the macrophages and dendritic cells, they can also act as antigen-presenting cells with MHC2 receptors. They circulate and travel through peripheral lymphoid tissue like lymph node follicles, the white pulp of the spleen, and unencapsulated lymphoid tissue in order to find antigen. When they find their cognate antigen, they differentiate into plasma cells, acting as an antibody-producing factory. Of note, activated B cells can also form memory cells, which are longer-lasting but less active than plasma cells and have the same antigenic specificity. The next time the same antigen is encountered, memory cells are reactivated and an immune response happens much more quickly as a result. An important clinical pearl for the boards is the fact that B cells can be infected by the EBV virus, causing mononucleosis. As we just stated, plasma cells are the descendants of activated B cells that function as antibody factories. As you can see, they have an off-center nucleus in what is sometimes described as a fried egg appearance. It's hard to see in this image, but other features of plasma cells include chromatin in a clock face distribution and well-developed Golgi. This cell is at the center of the pathology of multiple myeloma. In the pathology section of this chapter, we will discuss this cancer of plasma cells in more detail. The majority of circulating lymphocytes are T cells, up to 80%. They are the workhorse for the cellular immune response. T cells are created in the bone marrow but mature in the thymus, hence their name. Remember that B cells mature in bone marrow and T cells in the thymus. Immature T cells can mature into three different types of cells: cytotoxic T cells, helper T cells, and suppressor T cells, with the first two being the most important to remember. Cytotoxic T cells have CD8 co-receptors that interact with MHC1 receptors found on most cells. This photo shows a cytotoxic T cell. Immature T cells can also differentiate into T helper cells with CD4 co-receptors that interact with MHC2 receptors on antigen-presenting cells. A good way to remember this is that MHC times CD equals 8, such that MHC2 times CD4 is equal to 8, and MHC1 times CD8 is also equal to 8. Regardless of the type, T cells usually need a co-stimulatory signal to get activated, which can be provided by CD28. For more details, please refer to the immunology chapter.